Okay, hello, I'm Eric Rush. I'm a clinical geneticist at Children's Mercy in Kansas City, Missouri. I'm also a clinical geneticist at the University of Kansas Medical Center in Kansas City, Kansas. Today, I'll be discussing bone loss in peroxisomal disorders. So before we get started on talking a little bit about bone biology and some of the treatments that we use in people with peroxisomal disease, I want to talk a little about what the problem is as we see it. And the problem is that we see enough children with peroxisomal biogenesis disorders and Zellweger spectrum disorders that have been found to have decreased bone mineral density. And those patients may also have bone pain, fractures, impaired mobility, and there is at least some suggestion that there's decreased energy for these patients. Before we go further, I want to talk a little bit about what bone is. In a previous version of this slide deck, I have a picture of a rock and a pipe because I think people think about bones as these kind of inert structural elements. But bone is really very much alive, and it's a very dynamic tissue, and it's composed of a lot of different things. And one of the things that bone is comprised of are cells, which shouldn't be surprising to any of us. But some of the cells that I think are important for us to consider are osteoprogenitor cells. These are immature progenitor cells, and these eventually will differentiate into osteoblasts. Osteoblasts are the bone forming cells. They produce a substance called osteoid. And osteoid is the protein component of bone. And then those osteoblasts then mineralize that osteoid into mature bone. So osteoblasts are very important. Osteocytes are osteoblasts which have become trapped in the bone matrix, and they remain in these little lacunae. These little areas of bone that's formed. And osteocytes are not perfectly understood, but we think they probably work to maintain nearby bone and keep it healthy. And they also secrete certain hormone substances that are important for maintenance of things like phosphate levels in the body. And then osteoclasts, these are cells that resorb both the mineral and the protein matrix of the regions of bone that become old or damaged. And that's really important to have both osteoblasts and osteoclasts in your bone that are working appropriately well. So what is the extracellular part of bone? Well, we just call it the extracellular matrix, and it's organic, meaning it's composed of carbon-containing molecules. And one of the substances that's very important in bone is collagen. And there are currently known to be 27 different types of collagen, but this is collagen 1. And as its name implies, it was one of the earliest ones to be discovered. And it's also very important, noting that about 85 to 90% of the protein within the bone is collagen type 1. There are some minor contributions from other collagens and different proteins called osteocalcins, and then also other kind of protein sugar substances called glycosaminoglycans. So this is what the organic matrix of the bone is comprised of. And the inorganic part of bone is the hydroxyapatite. This is bone mineral, and this is what all the fuss is about in many patients with ZSD or really other conditions that affect the density of the bone, as we worry about decreased bone mineral density. And here's just a little bit about the bone anatomy. So there are different kinds of bone, and in different positions and in different bones in the body. And so some of what we see in the ends of the bone are what we call spongy bone. And the spongy bone is you can see is porous. The little trabeculae are a little bit thinner. You have marrow that's running through part of it. And the articular cartilage is along the surface of that spongy bone. In the shaft or the diaphysis of the bone, what you will see what's called compact cortical bone, and that is thicker. It lends a lot of structural strength to the bone, medullary cavity that the bone marrow is in, and all of the bones are covered by what's called periosteum, which is a highly innervated vascular tissue that is very important for kind of maintenance and health of the bone. And then there are arteries that will penetrate the bone at various points. And so that's just a little bit about what bone looks like. What about how bone is repaired? And so there's an important aspect of this that concerns bone forming. And there's a lot of different mechanisms by which that happens. The most common way is what we call endochondral bone formation, where the cartilage actually forms a scaffold. and then the bone mineralizes around that cartilage scaffold. This is the way long bones are formed. And there's another type of bone formation that is called membranous or intramembranous bone formation. And what that is very, very different. It's not that cartilage scaffolding. It's that there is a region of the bone or the region of the body where there is a need for bone to form, and then stem cells that will eventually differentiate into osteoblasts are recruited to the region, and they will start laying down that bone matrix, and then it kind of forms in a couple of different layers, and then you eventually will have these bones formed, and these are generally flat bones like skull bones and ribs that form in that fashion. And so what about the bone repair? Well, bone is repaired by the osteoclasts, and the pre-osteoclasts are recruited to the bone resorption site, and then they differentiate into active osteoclasts. And those active osteoclasts will secrete acids. They'll secrete collagenases, and that will end up digesting the bone matrix. And then the pre-osteoblasts are then recruited to the site where there's now a defect in the bone. And then osteoblasts will then come and they will form bone, and that bone will be mineralized, and some of those osteoblasts will be trapped in the bone lacunae as osteocytes. And there are some really important nutrients that we will talk about very briefly, and one is calcium. The body contains about 1,000 milligrams of calcium, and most of it is locked in the bone mineral, and about 1% of it is just in the blood, extracellular fluid, and soft tissues. And so we can see that the bone is really kind of our storage method of calcium. And if the calcium in the blood, about half of it is in ionized state, and about half of it is bound to proteins. About 10% is complex to different anions. And it's important that in the body that calcium levels be really tightly controlled for optimal functioning. And this is usually done by the parathyroid gland. The parathyroid gland is kind of a beastly little gland. And so if you have inadequate amounts of calcium that are present, you will release PTH. Once your calcium level drops below a certain point, the calcium sensing receptor will note this, and more parathyroid hormone will be released. And its job is to keep those calcium levels in the blood as normal as possible. And it will really do this at all costs. And some of the things that it does that are generally a good thing are absorption of the dietary calcium in the intestine being upregulated. That's probably okay. Resorption of calcium in the kidney is increased. No, that's often probably okay. But liberation of hydroxyapatite from the bones, we generally don't want that. And so that can be a real problem when we have people that have inadequate amounts of calcium that are either in the bloodstream or they're being delivered to the appropriate place. Phosphorus is just a little bit different. Most of the phosphorus is in hydroxyapatite, but there's a little more in soft tissues. Phosphate has a lot of different functions within the body, and so there are different locations where you're going to find it in the soft tissues, and it's generally absorbed in one of two ways. There's kind of a passive concentration dependent absorption of phosphorus, and then one is what we call active transport, just using vitamin D, and because vitamin D is very important in the absorption of calcium and phosphorus from the gut. And then usually it's excreted by the kidneys. It's filtered out, and then some of it is reabsorbed in the kidney, and PTH is also very important for clearance of phosphorus from the kidney. And I also just want to touch very briefly on a phenomenon called disuse osteoporosis. And this is something I want to touch on because it's come up in the discussion for patients with ZSD, because I think there was previously an assumption that bone loss in this condition was just due to skeletal unloading, because this is a neurologic condition that will often reduce mobility. And it is true that mobility impairment will have a tendency to promote bone loss. And we know this for bedridden patients, and we know this for people that are in long-term free fall. When they're in space, they will have a certain amount of bone loss because of that. And generally in disuse osteoporosis, bone loss tends to be regional and will correspond to regions which aren't under load. And oftentimes in patients that are in wheelchairs and are predominantly in a seated position, we'll find that they don't have as much disuse osteoporosis in their spines, which are still under load, as they do in their femurs, which are not under load. So you'll see some of that asymmetry in those patients. And we'll also see in disuse osteoporosis that there's overall a negative calcium balance that's observed in these patients prior to loss of bone mineral density. They'll start excreting more of it. And there's also some hormonal changes, PTH, vitamin D, growth hormone, testosterone and estrogen have all been implicated in the pathogenesis of disuse osteoporosis. So it's actually kind of complex. Which leads us to a discussion of how we would evaluate people with ZSD or PBDs for bone disease, and it's a combination of different things. Obviously, a lot of it starts with clinical manifestations. It's important to take a careful history, do a careful physical exam. But then when we're acquiring radiology, we're interested in doing things like skeletal surveys. We want to do bone density, and we cheaply do bone density in everybody on what's called DEXA, or dual energy X-ray absorptiometry. For as far as labs are concerned, it's important to measure kidney function, electrolytes, phosphorus, calcium levels in the blood and urine. The 25 hydroxy vitamin D levels. 25 hydroxy vitamin D is the way we store our vitamin D in the body. And so if you're looking for vitamin D deficiency or sufficiency, that's the level you want to measure. And then also uniquely in people with ZSD and other disorders which can cause malabsorption of fat soluble vitamins, you're going to want to look at vitamins A, E, and K in addition to vitamin D. And we also want to take a careful history and note which drugs might be present that could be contributing to bone loss. And one of the more common ones we see just in everybody is going to be glucocorticoids. An example of this would be prednisone or methylprednisolone. These are commonly used. These are commonly used in the acute setting, and in the acute setting, they're generally well tolerated, and it's not usually a huge problem. If somebody's on a week of steroids for an asthma exacerbation, once every few years, it's probably not going to be a big deal, not going to really matter for your bone density. But if a person's on chronic high dose glucocorticoids, it certainly can be. PPIs, proton pump inhibitors, these like your meprostactine, esomeprazole, or Nexium, can have some negative effects for bone for sure. Progestin-only hormonal treatment. These are things like Depo-Provera can have negative effects on the bone. A lot of your anti-seizure drugs, particularly the older ones, can have a significant effect on bone. Phenobarbital, phenytoin, carbamazepine. These are some of the worst offenders, and so we caution to use, if possible, maybe a relatively bone-sparing anti-epileptic drug. And then to some extent antidepressants, and this is probably not a hugely prominent effect, but it has been seen at least statistically in tricyclic antidepressants and serotonin-specific reuptake inhibitors. And the SSRIs are much more commonly used these days just because of safety and tolerance issues, but TCAs are occasionally used as adjuncts. So how do we regulate a lot of this? This is a very careful dance of different cells and different hormones that are acting to be able to make bones. And there's a lot of regulation that needs to happen. And in healthy people, there's a balance between the construction of the osteoblasts, or the bone-forming cells, and adipocytes, or fat-forming cells. And it's interesting that these would be in the balance between them. We know that there are numerous signaling pathways that exist to regulate the balance between forming fat cells or forming bone cells, but there appear to be kind of two master switches that regulate between what we call adipogenesis, or the tendency to make more fat cells, and or osteogenesis, the tendency to make more bone cells. And one is called PPAR gamma, that we think is a regulator of adipogenesis. And so if you're secreting a lot more PPAR gamma, you're going to make more fat cells. This has some implications, probably not only in ZSDs, but also probably has some implications in really common conditions, like, for instance, type 2 diabetes, and also probably has some effect on just normal aging, where we all develop a little more fat and a little less lean tissue. And then the other hormone that's really important is RUNX2. So RUNX2 is very much an osteogenic transcription factor, and so the more RUNX2 is being stimulated, the more bone you're going to tend to get. So these are some master switches. Obviously, the truth is far more complex than this, and there's a lot of different regulatory mechanisms. They're kind of beyond the scope of a talk like this, but I did want to give everybody sort of just a little taste, a little flavor for kind of how we regulate osteogenesis. And I'm going to discuss very briefly a little bit about treatment, because that's a question I get pretty frequently, maybe a little more than I get the kind of the bone biology lecture. But so I do want to discuss treatment a little bit. And I've condensed this a little bit just for time. And so just suffice to say, the drug that we're using chiefly in people with PBD-ZSD are the bisphosphonates. Bisphosphonates are what we call anti-resorptive agents, meaning that they're taken up by osteoclasts, by those bone resorbing cells, and they directly inhibit a number of enzymes in a cholesterol pathway. This is called mevalonate kinase, and they inhibit production of a couple of cholesterol intermediates called farnesyl diphosphate and geranyl diphosphate. Well, why would that really even matter? As it turns out, these are really important cholesterol intermediates that activate certain proteins, and they kind of regulate the function of those osteoclasts. They sort of keep them active and keep them alive. And so if they're not there, the osteoclasts, they tend to not work very well, and some of them actually tend to die off. And so that's why bisphosphonates will work to decrease that bone resorption. And so it gives the bone a little bit of an opportunity to sort of build up a little more about that bone density. And we started using these in osteoporosis many years ago, but then about 25 years ago or so, they started using them in osteogenesis imperfecta, which is the most common brittle bone disorder. And we've been using them for about the last couple of decades. And there's lots of different studies that suggest that they do increase bone to mineral density. Also suggests that that people will have fewer fractures, probably have reduced bone pain, and seemingly an improved functional status. Again, there's a moderate level of evidence to support this, but unfortunately these are observational studies, and nobody's really going to do a randomized clinical controlled trial for drugs that are generic, and I don't know that it's really ethical to do that anyway. So we have kind of the evidence we're going to have with this. And so I think we can retask some of our philosophy that we do for patients with osteogenesis imperfecta, for patients with PBD-ZSD. And so but I do have some suggestions for how we might do that in a way that's a little safer. So suggestions for bisphosphonate in therapy include patients really should be clinically well for at least a week prior to having the infusion. And I prefer to have certain labs prior to the infusion, just to make sure that everything is looking good as far as renal function, liver function, kind of the phosphorus and vitamin D status. Serum cetalopeptides is kind of a special measure of kind of how the bones are turning themselves over. And can be helpful to do. And so for initial infusions, I generally still will admit patients overnight between that first and second infusion and make sure they tolerate it okay. The good news is most of the time this is not a problematic stay, it's more of a boring stay. But sometimes people can have some adverse events that are associated with this. And a couple things that are unique for the preparation for patients with PBD-ZSD would be for those patients who have existing adrenal insufficiency. I would really strongly consider stress dosing them with their steroids during their first infusion. You can also give Tylenol and Benadryl for those patients. I generally we use pimidinate as opposed to zoledronate, just because I think it's easier to dose, because we're really giving really tiny doses of these medications, and we want to do it that way. We want to make sure that we're giving a relatively low dose for safety reasons, and so we target a therapeutic dose that is a little bit less than what we shoot for in our osteogenesis imperfecta patients, but we think it's likely to be enough to make a difference. And we also want to make sure that the calcium level doesn't drop after infusions. And so after you have that initial infusion, what you do next, that venue for subsequent infusions, really depends on the success of that first infusion. If you do great, you're probably okay to go to an outpatient infusion center. If you struggle a little bit, maybe you should go back into the hospital. It really depends on the person. Even if a person doesn't have known adrenal insufficiency and stress dose steroids are not given prior to the infusion, I would say providers should have a really low threshold to stress dose later on if concerns develop. I mean, if a person gets this infusion and is really struggling with some signs and symptoms, it could be compatible with an incomplete stress reaction because of this. We really would want to consider that stress dose, because there are some things that we know that are important caveats with bisphosphonates, and those include some known side effects. And this can include a fever and flu-like reaction that often will occur with the first infusion in patients for any indication. Rare but not uncommon are going to be things like hypocalcemia, low calcium level in the blood, and that can happen with any infusion. It's much less likely to happen with the low doses of pimidinate that we're using for patients with this condition, but it doesn't mean it couldn't happen. There are some theoretical concerns for things like osteonecrosis of the jaw, where a portion of the jaw actually will die off and have to regrow, and sometimes you'll have to have actual surgical debridement to get rid of that dead tissue. I've never seen this in a pediatric patient. I've only seen it in older patients. It's a theoretical risk in everybody, but I think it's extremely low in children. And there's also a risk of what we call bisphosphonate-associated inflammatory reaction. These are patients that will have more of an extended fever and flu-like reaction. A lot of them can have significant bone pain with their infusion. I see this more with people who are on higher dose therapy. I see it more with adults who are treated, especially my adults with osteogenesis imperfecta will sometimes get this with their first or second infusion. I really don't see it a ton with people with ZSDs, but you could definitely see it. But overall, I do think the side effect profile is a little more significant in these patients. That inflammatory reaction is probably more common than kids with OI. Some of them will have high fever, malaise. Some of them will have been found to have low blood pressure. Vomiting, nausea appear to be more common. I tell people to really watch for this. Hypocalcemia may be more common. It's not really clear at this point, but it might be more common. And I haven't seen anybody with osteonecrosis of the jaw with this condition, and I don't really expect to. So how do we keep track of these patients over time? Well, we want to do a yearly bone density when they're on treatment, and we want to follow their labs that they had with the infusions. And we really want to follow that vitamin D level and shoot for a good 25 hydroxy vitamin D level of around 40 nanograms per milliliter. That's kind of what we would consider to be sufficient. And then we also want to do a yearly assessment for well-being and function by a provider who's familiar with this condition. That's very important as well. There have been some additional discussions of treatments, at least considerations, and some of those things can even include treatment with estrogen and testosterone. These are generally considered anabolic agents. They really haven't been studied in any great detail in rare bone disease. We certainly have used estrogen for women who are going through menopause to preserve bone density, and they are effective at that. There is some risk involved, but they are effective at that. But we really don't know the efficacy in inherited bone diseases or rare metabolic diseases like this one. And then there is getting to be more interest in a group of treatments that inhibit the activity of a signaling molecule called sclerostin. And what sclerostin is it kind of forms sort of a brake on the function of the osteoclast. It sort of tells the osteoblast, excuse me. It tells the osteoblast, hey, you need to slow down. You need to not make so much bone. And sometimes sclerostin acts a little too much and you don't make enough bone at all. But sometimes if you're not making enough bone for a completely unrelated reason, and you can dial back a little bit on the sclerostin, you might be able to increase the overall effectiveness of building bone. And this has been studied in osteoporosis, and it's currently being studied in OI. But it's possible that it may show some efficacy in low bone mineral density and other disorders. We just don't know yet, but it's an interesting set of interesting molecule or interesting group of molecules. And so I think there'll be more discussion of that later on. So thank you for allowing me to talk to you. I'm sorry I couldn't be there in person.